health. Okay, next slide. So I don't have any conflicts of interest. Next slide. So this is a patient I saw 1 month ago at urgent care. He's a 32-year-old male, comes in complaining of brain fog, sore throat, fatigue, lymph node swelling, and sinus congestion for 5 days. There's coughing, clear sputum as well. He has a history of seasonal allergies for which he takes Zyrtec daily, and he's never been COVID tested. He's fully vaccinated, but not boosted against COVID and not vaccinated against flu. Vitals were stable. He thinks he has a bacterial sinus infection and asks for antibiotics. So this is interesting because here was a patient having sinus symptoms and sore throat, but he was also complaining of brain fog for the last 5 days. So what do you think we should do next? Anyone?
And Sarah, I'll monitor the chat for you in case we get any comments.
Okay.
COVID test.
That's a good idea. Anyone else?
We got a chat in also saying test for COVID.
Okay, so COVID test is a really good idea. And so what we did was we tested him for a fourplex. So a fourplex is COVID along with RSV, as well as the flu A and flu B, given the fact that he wasn't vaccinated against flu either, and COVID because he was clearly having symptoms. And then we also did a strep test as well because of the complaint of sore throat. I won't tell you the results right now, but we'll go on to the next slide. So what is brain fog? Brain fog is a usually temporary state of diminished mental capacity marked by an inability to concentrate or to think or reason clearly. This is taken from Merriam-Webster, and then occupational health is an area of work in public health to promote and maintain the highest degree of physical, mental, and social well-being of workers in all occupations. Next slide. So now we want to be clear about what is acute COVID and what is post-COVID, because these things have been going around and these terms have been floating around for a while. So acute COVID is usually taken as symptoms of COVID-19 up to 4 weeks following the onset of illness or following the onset of the first symptom. And then a post-COVID condition is a wide range of symptoms and effects that develop during or after COVID-19 and last for at least 2 months. And 3 months from the onset of illness or 3 months from the onset of the first symptom. Those symptoms are not explained by an alternative diagnosis. People call post-COVID by many names, including long COVID, long haul COVID, post-acute COVID, post-acute sequelae of SARS-CoV-2, which is also known as PASS, and long-term effects of COVID and chronic COVID. So I took these from the WHO and the CDC websites. Next slide. And so post-COVID conditions has also been recognized in the ICD-10 as a specific condition that we can bill for and code for while we are seeing a patient. And this code became effective October 1st, 2021. Next slide. So this is a little graphic I made, and what it shows is that acute COVID is from time 0 till time 1 month. So that's acute COVID, and then symptoms lasting for 2 months at least, and within 3 months from the onset of illness. That's classified as a post-COVID condition. So anything that starts from time 0 till time 3 months, any symptom, any COVID-related symptom, that would be a post-COVID condition. And if it starts after 3 months, it's likely not a post-COVID condition. Next slide. So as far as the epidemiology is concerned, this was a prospective study of 100 non-hospitalized patients, very recent with COVID-19, with symptoms that persisted for at least 6 weeks. And here we can see that brain fog was one of the primary symptoms. It was around 81%, and the rest of the symptoms were less frequent, like headache, numbness or tingling, loss of sense of taste or smell, and muscle aches. Next slide. So this is a table I took from UpToDate. What it says is that there's all these symptoms that are persisting after COVID, including fatigue, shortness of breath, chest discomfort, cough, loss of sense of smell. And then there's also less common physical symptoms like joint pain and headache, but there's also psychological and neurocognitive symptoms, which are PTSD, impaired memory, poor concentration, anxiety, and depression. And what we're focused on here is mainly the impaired memory and poor concentration, which we call in late terminology as brain fog. And that lasts weeks to months, and that is found in approximately 16 to 18 to 21% of people. Next slide. And this data was actually taken from the Ecuador study, the one in UpToDate. And of 93 individuals, 52 had a history of mild COVID infection. They were seropositive and they had symptoms. So both of these things, having the blood markers and having symptoms. Some individuals did not have clinical manifestations and were seronegative for SARS-CoV-2. But what they found was that post-pandemic, Montreal cognitive assessment scores were worse in the ones who were positive for COVID and who had symptoms as well. So compare seropositive versus seronegative, 21% versus 2%. That was a cognitive decline that was seen. And the odds for developing cognitive decline were 18.1 times higher for COVID positive individuals. Next slide. And here we can see a graphical representation of how the patients were followed pre-pandemic, and then they were followed pre-pandemic, and then post-pandemic there was a reduction in their MoCA scores, and the ones with positive serology had a greater decline of MoCA scores. Next slide. And this was from a 6-month retrospective cohort study that said that cognitive symptoms were observed in 7.8% of patients after COVID-19, with higher incidences in the elderly and those hospitalized or needing ICU admission. So definitely we can see that cognitive symptoms occurred during or after COVID-19, and they were more in elderly or in those hospitalized or needing ICU care. Next slide. And then there were some individuals that had a more delayed onset of cognitive symptoms, and those were more younger patients. So that can be also thought of as well when looking at different ages of patients as well. Next slide. So what are the possible etiologies that might cause brain fog related to COVID-19? So there were a number of etiologies put forward. One is possibly a lack of oxygen caused by lung damage. Another very popular is inflammation that is affecting the brain cells. And then one is an autoimmune disorder that's causing the immune system to attack healthy cells in the body. And lack of blood flow caused by swelling of the blood vessels in the brain or disruption of the blood vessels in the brain. It can also be an invasion of infectious cells into the brain as well. And then what was found was that a higher number of pre-existing cognitive risk factors were associated with brain fog as well. And those pre-existing cognitive risk factors included pre-existing depression, anxiety, having a diagnosis of ADHD, diabetes, hypertension. So all of these things did predispose a person to have brain fog, and a combination of these factors could also be responsible for it. Next slide. So what are the clinical manifestations? People have memory issues, difficulty remembering what you just read, why you entered the room. People are distracted or not able to follow conversations. There's also difficulty concentrating, difficulty with ADLs, IADLs, dressing, eating, ambulation, using the toilet, showering, shopping, housekeeping, finances, food prep, driving, all of these things. And losing train of thought, word finding difficulties, taking longer to complete tasks, forgetting steps for cooking, forgetting recipes, or leaving the lights on. And these emerge when people get ready to go back to work. So that happens, and it can impact job performance and quality of life. Next slide. So how do we diagnose brain fog or cognitive dysfunction? We do a history, physical exam. A simple physical exam, a neurological exam can tell whether a person has some memory issues. And then more formally, you can also do cognitive testing of the patient. And then for most patients, it has been physicians tend to not take brain fog seriously. Why? Because for most patients, lab and imaging test results showed no abnormalities or were non-diagnostic despite debilitating symptoms. And it's true. I mean, brain fog related to COVID-19, you can think of it as a brain injury sort of thing, only that it's not traumatic or not preceded by specific trauma, but it's just preceded by specific infection that can cause either inflammation or autoimmunity. Next slide. So these are some investigational methods that can be, so some CSF markers and some markers in the plasma, they can be elevated as well in people with cognitive symptoms. CSF markers, certain markers can be elevated, immunovascular markers after 10 months after acute SARS-CoV-2 infection. And then there are some markers associated with neuronal dysfunction, such as neurofilament light chain and plasma glial fibrillary acidic protein. And then this is another one, plasma SARS-CoV-2 nucleocapsid antigen. And these were seen in patients with persistent neurologic symptoms following either severe or mild COVID-19 infection. So what's interesting is that some of these markers can be elevated in Alzheimer's or frontotemporal dementia. So and it's interesting because it had even the actual cause or the actual etiology of Alzheimer's has not been demonstrated. What actually causes it? Could it be that certain viruses can be the possible etiologies of Alzheimer's, and we're just seeing this now, that this cognitive dysfunction could be the start of that, or it could be something that is actually caused by COVID-19 and has not been caused before by anything else. So that's a point of discussion and a point of future study as well. Next slide. And then we also had brain changes in 785 participants of a UK biobank study. Structural changes were more likely in people following COVID-19 infection, leading to a greater reduction in gray matter thickness in orbital frontal cortex and parahippocampal gyrus, as well as global brain size. And then there were more markers of tissue damage in regions that are connected to the primary olfactory cortex, and hence explains the loss of sense of smell and taste. And then COVID-19 patients also showed a greater cognitive decline between 2 time points. Next slide. So how do we prevent brain fog or COVID-19? Definitely vaccination, hand hygiene, social distancing, wear a mask, covering face while sneezing or coughing, and cleaning and disinfection at home, and stay at home if there are symptoms. And right now, the CDC guidelines say 5 days of quarantine. Next slide. So how do we get around brain fog? There are some tips and tricks that we can do, or we can counsel patients to try, such as using notes or to-do lists for help with memory, using word associations to help remember words, get rid of distractions, building endurance. And so research has been found that mindfulness training or meditation can actually help cognitive function. So this is something that can be prescribed to patients as well. And then physical activity. And now patients might say that getting from point A to point B, I have so much fatigue after COVID. So graduated increase in physical activity is very important. And that's where a sports medicine physician or an occupational medicine physician can come in handy. And validation, of course. Patients do not need to be, after being through all of that, they do not need to be told that you're just imagining things. But instead, validation is very important for a good physician-patient relationship, and also to build trust, and also the fact that it's an actual thing, that that there is brain inflammation after COVID. And then there might be a referral needed to cognitive rehab, and that can possibly be done if all of the other steps are not helpful for the patient. Next slide. So what happens with cognitive rehab, we teach patients to optimize sleep, improve sleep hygiene, because sleep is very important for cognitive repair, and then energy conservation, and then impact of physical movement, including exercise, and how to breathe well. And deep breathing exercises can be taught for stress management, and then optimizing diet, having a balanced diet to optimize energy levels, pacing and grading of activities, and how to optimize energy through regular and rest periods, optimizing breathing, of course. Next slide. So what's the prognosis of suppose someone has COVID-19 associated brain fog, and how long do they take to get better? So a recent study examined a range of cognitive functions essential for daily life, and people who had previously suffered from COVID-19 but were not significantly different from a control group on symptoms, on other symptoms such as personality profile and fatigue, forgetfulness. And then COVID-19 survivors performed well in most abilities tested, including memory, function, and mental rotation, but they displayed significantly worse episodic memory up to 6 months post-infection, and greater decline in vigilance with time on task for up to 9 months. And so this was in patients who had asymptomatic or moderate COVID-19 and no residual symptoms after recovery. And so they so 6 to 9 months was the time period that they still continued to display worse episodic memory and vigilance. And then after 6 to 9 months, they were starting to get better on that. Next slide. And then again, this was also this is one of the prior slides, but this is from a 6-month cohort study that cognitive symptoms were continued to be observed 6 months after COVID-19 in about 7% of patients, especially who were elderly and who were hospitalized or needing ICU care. Next slide. And here you can see that cognitive symptoms are a little bit higher, like having different demographic characteristics of patient and different care characteristics of patients. We see that female patients had probably more cognitive symptoms, and again, age, a higher age was also associated with those as well. Cognitive symptoms were higher, and then ICU admission symptoms were higher as well for those, and people who needed hospitalization had a higher incidence of cognitive symptoms as well. Next slide. So does brain fog related to COVID-19 cause harm to the employee or other employees or the work itself? And that's the question we need to answer for the impact on occupational health. And then, is brain fog related to COVID-19, is that compensable? Does it arise as a result of work and during the course of work? Next slide. So this is from the information I took relating to occupational health is taken from the AMA guides to the evaluation of work ability and return to work. It is kind of a very good resource for occupational medicine. I used the second edition for that. Next slide. So chapter 6 of the AMA guides talks about the decision-making used for clearing a patient as to be able to work. It considers both the person and the environment. So number 1 is risk. Is the employee at harm due to his or her occupational activities? And is there a risk to other individuals? Number 2 is capacity. Is the employee able to perform his or her work activities? And number 3, which is the least crucial factor, is that the employee he or she able to endure sustained work activities. So physicians are patient advocates, and reducing the number of days away from work is in the patient's interest, and it gives the worker a better self-image, as well as a better ability to cope and be self-sufficient. And prolonged time away from work can make recovery less likely. So definitely being a patient advocate involves being a cheerleader for the patient and having them return to work as soon as they're able to. As I mentioned, risk is the most important one. We don't want harm harm occurring to either the employee or other employees. And again, number two would be like the capacity, their functional capacity that can be tested with certain, or keeping in mind their normal occupational activities versus what they're able to do. And that can be ascertained with the physical exam or cognitive testing if needed. Next slide. So brain fog is not listed in the AMA guides as a specific issue, but like I mentioned, that I can take it as being under the umbrella of brain injury as described in chapter 16, which COVID-19 can be. So for brain injury, the risk portion says specifically for brain injury, it says that the brain does not become injured or worse with activity. And patients with head injury are not at a risk of harm with activities for which they have the skills, unless if it's a safety sensitive work or if post-traumatic seizures are present. And so as far as risk is concerned, there is very low risk for just activities involving the brain or just thinking or doing any sort of work relating to that. And as far as capacity is concerned, with severe brain injury, people may lose some skills, and this can be dealt with a trial of supervised work activity. So a trial of work can be definitely tried, trial of work for a week, for 2 weeks, see how the patient does. And then if there's no change, or dealing with that accordingly. And then tolerance, there can be symptoms like malaise and fatigue, and they're not measurable or verifiable. And this can be dealt with work autonomy, in which the pace and rate of work are modified. And then, so the worker can be given a longer time to perform the same work, and at which they can control their pace. And then personality changes after severe traumatic brain injury can result in the loss of motivation. And I can imagine something like that happening with COVID as well. These are things that can be dealt with sufficient amount of patient physician trust and conversation. So next slide. Sorry. So this was a study, and that showed the percentage of individuals with cognitive complaints and people who were given a prescription of being out of work versus having modified duty or full duty. With modified being involved, they were able to do certain things and having some restrictions from their normal occupational work, and then full duty having whatever their occupational normal activities were. And here we can see that people who were either modified, people who had returned to work, or either modified or full, had a higher incidence of complaints for cognition versus, but people who were actually returned to work full duty had a lower incidence of complaints. And what this says is that people who might have returned to full duty might be it's very possible that those people do not have a sufficiently higher loss of cognition to begin with. And then people who are, as opposed to people who are out of work versus people who are still working with modified duty, when they return to work, they find that they're not able to do some things or concentrate or focus what they used to do, and that they feel that more strongly when they're at work as opposed to not at work. So this is an interesting graph. And let's look at the next slide. And then a recent article said that long COVID disabilities and absences could contribute to about 15% of 10.6 million unfilled jobs in the US. And the question was, is long COVID worsening the labor shortage? I would say probably, because it could potentially, as far as their calculations were concerned, they could contribute to 15% of unfilled jobs. And that is 1 out of 7 working age Americans. Next slide. So post-COVID conditions has been recognized as a disability as of July 2021. It can be considered under the Americans with Disabilities Act. There is no test to diagnose it yet. And people may have a wide variety of symptoms that could result from other etiologies. And this can make it tough for healthcare workers to recognize post-COVID conditions. And typically a diagnosis of post-COVID conditions based on history, including if a diagnosis of COVID-19 either by a positive test or by symptoms of exposure, as well as a physical exam. So the only people have been doing tests such as vitamin D levels, CBC, CMP. None of them, like I mentioned, they have any positive findings, and it's just the only test that's positive is usually the COVID test, either by positive test, or if the test is not positive, it could be just by symptoms or by exposure. Next slide. So this was one of the articles in Scientific American that warned of a tsunami of disability as a result of non-COVID, and we need to plan for a future where millions of survivors are chronically ill. And that's potentially something that needs more research into, like, as to how many people would be affected and what can be done. Next slide. So the patient that we discussed at the start of my presentation, they were negative for strep, negative for flu A and flu B, negative for RSV, but positive for COVID. And that was interesting because when the patient said, I specifically had brain fog and then a host of other symptoms. So that was interesting that he was positive for COVID-19, that he, even though he was vaccinated and he had never been tested for COVID before. So symptoms of brain fog and fatigue, as far as my follow-up of this patient is concerned, they have been progressively improving, and the patient is already back to his desk job. Next slide. So my key points here, brain fog or cognitive dysfunction can occur during or after acute COVID-19. So it can be either acute, or it can be part of the post-COVID syndrome, or it can be part of persisting symptoms. And recovery is usually anticipated within weeks to months, and people can vary widely in their recovery course depending on their demographics, as well as how severe was it. A history and physical exam with optional neurological cognitive tests can definitely be done. And if the patient is severely affected, we can have rehabilitation, or we can have accommodations at home or at work with a graded return to work or normal activities. Next slide. Questions?
Well, first and foremost, Sana, thank you so much. You did such a wonderful job presenting such an interesting and important topic, to say the least. So we really appreciate your time. And I just have to say, Elizabeth and I love that you included a case in there. So thank you for including that as well. It's very interesting. So we'll open it up to any questions, comments, thoughts from the group. And anyone is welcome to unmute. You can use the raise hand feature or chat in. We got a chat asking, are there any vitamins, herbs, OTC that could help with brain fog? Great question. Thank you.
People, so nothing that has been shown in research that could help with brain fog. Definitely having a balanced diet, that is very important for good energy levels. And if a person is not able to obtain their regular balanced diet, then in that case, vitamins might help. And I'm not sure about herbs. That's not my domain at all. Any comments about small case studies, case reports with famotidine and brain fog? Have not looked into that. That could be interesting. That could be a potential topic. Could you comment on any research showing that a COVID vaccine helps people recover from long COVID symptoms? There has not been a research showing that a COVID vaccine could help people recover from long COVID. I would probably say that having a vaccine could prevent further injury or inflammation as far as repeat infections are concerned. So that not help recover, but definitely prevention.
Thank you. You're awesome at facilitating and monitoring the chat as well. So thanks, Sana. Any other comments from the group, or if Dr. Martin? Yes.
Yeah, you know, when your resident presents that the residency director has to ask questions. Well, first of all, thank you very much for a great presentation, and thank you to the entire ECHO team for incorporating this into our program. We hope it's been of value to the participants. A comment of a clarification, the biobank study from the UK, did that actually involve examination of brain tissue? It looked like it did.
It involved imaging.
Oh, it was imaging.
Imaging, yes.
Okay. When I saw biobank, I thought it was more. My second question is, of course, being an occupational medicine practitioner, I'm reminded of neurotoxicology cases, traumatic brain injury, and other medically, well, no, in addition, some medically unexplained syndromes that are not well characterized, that we often see, like multiple chemical sensitivity. And these are very challenging cases for us to deal with. One of the things that we observe with those is comorbid mood disorders, especially with neurotoxicology. And of course, that's understandable. If there is a concern that you have damaged your brain through chemical exposures, it would be appropriate to have a mood disorder. But of course, mood disorders can impact cognitive performance. In the literature that you looked at, did you see any evidence of concomitant mood disorders as part of this?
Yes, definitely. There was one of the references on one of the slides I mentioned. This was, I don't have my presentation right now, but if you could just pull up my presentation. In the, maybe slide, the first 10 slides somewhere. I think it's 3 slides after. Oh no, yeah, in slide 14. Yeah. Okay, so this particular study, Balcom in 2021, that showed that there were higher, there was more cognitive dysfunction seen in people with pre-existing cognitive risk factors such as anxiety, depression, ADHD, so and PTSD as well. So.
Okay, thank you. And then the final question is, coming back to the demography, are you aware of any literature showing, I mean, you mentioned an Ecuador study, are there differences in the prevalence of brain fog among different countries?
That has not been examined yet, but that can definitely be a good area of further research.
Okay, thanks again.
No problem.
I have a question as well, Dr. Glues. So when you were talking about prevention, you really talked about prevention of COVID. And then you talked about management of post-COVID syndrome. So what I was wondering is, I know that there are some natural history studies that are going on. And I was wondering if they look at this, for example, let's look at all the ones who did not require hospitalization, but these got some therapy, whether it was steroids or this or that. And was there a difference between people who either got some therapy or didn't get some therapy? The problem is no one's going to come in to see you if they don't have post-COVID syndrome. And so it's going to be hard to actually find the people who were infected but serve as controls. So so is that why there's no data about this? Or?
There is no data about it. The fact that like comparatively like people with the same type of symptoms, like non-severe COVID, but what you're asking is like, what's the different factors that could be responsible for example, if a patient was treated with some sort of COVID therapy, the ones that were not too sick, like what was the difference in their symptoms? And to my knowledge, there has not been like a study for that. But definitely, I think demographics, as far as that is concerned, definitely pre-morbid conditions, anxiety and depression, and then people who are more like elderly can definitely have a more incidence of cognitive symptoms. And again, I guess this is where like we have like a multiple etiologies could be responsible for it. Could it be just Alzheimer's, or could this be something else? And could this be just normal function? So yeah.
So you know, I do pediatric infectious diseases, and I think a lot of the family doctors and community pediatricians and so on, when they have a patient who come in with post-COVID symptoms, they are more or less just as befuddled about what to do with them as. So what they do is that it seems to me that they're sending them to infectious disease. Either they're adults, they send them to our adult ID colleagues, or they send them to us. And so what we should be encouraging them is to send them all to you. It sounds like you're going to help them more than I can.
As far as I'm sure we don't see a lot of pediatric patients, but sports medicine does see them. Not so much in OCMED, but sports medicine does see a lot of pediatric patients, especially like after concussions, that kind of thing. So,
Right, but not post-COVID usually. Right?
Not post-COVID, no. I think like recently PMNR people have been doing a lot of work with that. So they could potentially be some.
Yeah, that's a really good. We now have 2 pediatric PM&R, so that's good. And so the other thing that this is more of a comment, but you know, you have TBI and you have post-COVID brain fog, and the problem I think with both of them that you almost never have pre-morbid testing. So you're going to test these kids, and they're going to come out how they're going to come out. So for example, we see kids like, I have brain fog and I just can't do calculations in math, you know, like, oh, what kind of grades did you get before? A's. What kind of grades are you getting now? A's. And acing the AP tests, because, but I used to be able to do the calculations in my head much more quickly. I mean, I'm sure it's 100% true, but it's hard to test for those sorts of things, I guess.
Yes, definitely. I agree with you. And this is where like research has that flaw that before they had COVID, did they have that sort of testing? And how do we know that this wasn't a change? So that's where some of these like cohort studies come in. And there has been 1 or 2 studies like that, but not very many. So.
Thank you all so much for the questions and comments. Any other thoughts from the group? Do the little echo pause here and wait to see if anyone unmutes. Alrighty, well, if there are, as always, questions after the fact, just shoot us an email and we'll send it over to Sana to have addressed. I do have a couple housekeeping things that I was hoping you all could hang on for. But first and foremost, thank you so much, Sana. We really appreciate you. I know I already said that, but can't express the gratitude enough. Also want to thank Dr. Morton and Robin for helping to organize this collaboration. It's just been so wonderful. So thank you both as well. So the last thing is after the announcement, I was going to launch a brief poll. So if you all can hang on and fill that poll out, it'll be immensely helpful and we'll appreciate that very much. So the only announcement that I really had was that we're going to be making these COVID-19 echo sessions into sort of a pop-up session, I guess you could call it. So we'll only hold sessions if anyone submits a question or a topic request, and I'll have Elizabeth chat in the link where you can go to chat those topic requests or questions in. I'll also include it in the recap email, so you guys will all have that in email as well. And of course, fingers crossed, nothing too crazy happens or arises with COVID, but in the event that it does, of course, we're going to organize a session to address that as well. I saw we have a question from Susan in the chat as well, so I'll take note of that and then make sure it's addressed, and I'll email that to you as well, Susan. So I just wanted to let you all know you're always welcome to reach out to us if you do want to see a session revolving around COVID in any way, and we'll work to find an appropriate presenter to present on that topic and address any questions. So if we do have those pop-up sessions, they'll still remain on the third Thursdays of each month from 12:15 to 1:15. So thank you all so much. Let me go ahead and launch this poll. Is everyone able to see that okay? Thumbs up, nods, heads nodding. I'm a little you all knew what I meant. Okay, awesome. Thank you. Anytime you complete this poll, you can just go ahead and log off. And we hope to see you all next time if we have a pop-up session. Thank you all so much.
Thank you, everyone.